dysphagia, that is painful deglutition, along with hiccups, nausea and vomiting. But the most important thing is there can be extra esophageal manifestations also. So the most laryngitis, hoarseness can also be seen with globus sensation. Globus sensation is a very typical feeling of dysphagia. Endoscopy is normal, but the patient will have a feeling just. There is no other findings. So these are the symptoms by which patient comes to us. So there are many other troublesome problems with syndromic presentation of our patients, like with Barrett's, strictures. Even at the end they can present to us sometimes with cancer, that is adenocarcinoma. So we have to be very careful in choosing and investigating our patients. Now there has been very good studies regarding symptoms that even up to 10,000 of symptom episodes were investigated in more than 2,000 patients in this study. But still there are few symptoms which cannot be defined, like sharp rising pain in the food pipe. Now this is very difficult to define, but this is also the manifestation of reflux disease, along with some blocked feeling, sensation of something caught in the chest. हमारे पेशेंट आगे कहते हैं कि चेस्ट में बड़ा भारीपन सा है. Now you can differentiate with atypical chest pain, but this can also be the manifestation of reflux disease. Now the reflux disease is very common, almost 20% in the Western literature. In Indian literature, this prevalence is almost reported from 10% to 30% in general population, which increases with age, obesity, high fat diet, tobacco, alcohol, and some medicines which patient used to take regularly. So this is very common. But the good thing is that these reflux disease is most of the time is uncomplicated. Patients present to us with non-erosive reflux in 70% of the cases, erosive in 35%, and just a narrow number of 5% which will having the complicated presentations. Now a little bit on pathophysiology, because whenever we want to treat the reflux disease, we have to see the patients. There is a very good anti-reflux barrier in our this G junction complex with some mechanism of reflux, but hiatus hernia breaks this mechanism, so this causes reflux disease, along with the methods of acid clearance and gastric factors, which I will elaborate. Now anti-reflux barrier is basically starts with lower esophageal sphincter, which is strengthened by diaphragmatic crura with intra-abdominal location of some part of esophagus. This whole system creates a very tight sphincteric function of esophagus along with ligaments and angle of His. Now mechanism of reflux, we should know that reflux is sometimes physiologically normal. That is transient lower esophageal sphincter relaxations which are normal, along with whenever we swallow there is relaxation of LES and there can be some reflux. Now this is all normal. But whenever there is hernia, we know that surgeons are here, there is the normal displacement of LES, this reflux increases. Now this increase in reflux with increased relaxations causes more problem as there is some formation of acid pocket. Now this is a new concept of acid pocket which we will see later on. So there is a mechanism of esophageal acid clearance also for avoiding reflux, and that is volume clearance as well as chemical clearance, which is done by the salivary as well as esophageal gland secretions. Now along with that, some gastric factors are there which increases this reflux, that is gastric acid secretion, which can be higher on some patients which are high acid secretors, along with duodeноgastric reflux and few causes of delayed gastric emptying which very commonly seen in obese and diabetic patients. So this is the pathophysiology for reflux, that is along with lower esophageal sphincter, esophageal defects and stomach. Now clinical course in these patients is typically non-erosive, non-complicated, which is most common, with some excessive reflux of acid which can be normal but sometimes they have functional heartburn. It will progress into erosive disease, which is more common with male, old age, with overweight patients, with hiatus hernia, and these patients will develop more complications. Along with Barrett's esophagus, which is the metaplasia of esophageal epithelium. And that can further result into finally into the cancer, because this Barrett's esophagus is a pre-malignant condition. Now how can we diagnose this reflux disease? Very simple. If nothing is available, the empirical trial of acid suppression, that we commonly use PPI drug for 2 weeks to 4 weeks, and if it relieves the heartburn, then it goes in favor of reflux disease. So this is also accepted as a test if there is no complication, no alarm symptoms. Along with that, endoscopy is the best way of diagnosing basically erosive reflux disease. Normal endoscopy does not rule out, because non-erosive reflux disease, in those cases endoscopy can be normal, and there we need to go for further manometry as well as pH monitoring we have to do to assess. Now, endoscopy typically has these pictures with Los Angeles classification. We all know that small linear ulcers less than 5 mm will be classified as grade A, more than that grade B, and then grade C and grade 4 with grade D with complications of stricture and other Barrett's, presence of Barrett's. Now reflux testing, which actually clinically done in very limited cases where everything comes out to be normal, or a patient is labeled as refractory GERD, which I will be covering later. So this pH manometry, impedance manometry is now available. In some difficult cases it is definitely advised, so that better medicines or to the point medicines can be given to the patient. Now functional heartburn is again a topic here, because with acid exposure, with manometry, even there are few patients in which your manometry will be normal, your endoscopy is normal, but still patient complaints of heartburn. Now these are called typical functional heartburn patients. They have been very well classified into Rome 4, and this number of patient is very common in GERD category, with almost up to the tune of refractory patient in almost 60%. Now functional disorders are the diverse group. There is basically mucosal sensitivity, higher side with chemical stimulation which can be proved, and they have worsened central perception of pain. So these group of patients will have a definite different drug of treatment, which are very total different group of drugs. So the diagnosis is very important. Now reflux disease can have some complication like ulcers, hemorrhage and perforation, which are uncommon, but they can be life-threatening, requiring emergent intervention. So peptic esophageal strictures will need dilatation if ignored, and Barrett's esophagus, as I have already covered, they are asymptomatic pre-malignant conditions, and these are the indication for long-term PPI therapy. Now treatment, we all know that if these are the high-risk patient, first and the foremost important treatment is lifestyle modification, that is simple elevation of head, losing weight, restricting alcohol and smoking, dietary changes, refraining from lying down after meals, avoiding bedtime snacks. These are the very simple things with which almost 2/3 of the patients respond very well with short course of medical therapy. Medications, we all know PPI is very commonly used. H2RA is uncommonly used but definitely useful in nocturnal acid breakthrough with PPI. Prokinetic drug increases the LES tone and increases the gastric emptying. Has to be given sometimes if they have predominantly bloating type of symptoms along with reflux, and some difficult cases in which we can document that there is reflux because of transient, then baclofen group of drugs is also useful. So this is the flow chart by which we follow the drugs: lifestyle modification, acid suppression, LES support, and targeting the acid pocket. Now this acid pocket is a new concept. After using antacids has been used for almost 100 years, but they have a very transient relief, very small time relief, and may not provide symptomatic relief for long time and long enough. So we have to use some other drugs. Now acid pocket is a concept which is very well accepted now, has been studied physiologically, and this is very common. It occurs normally also. After meals there is a upper layer of acid which forms in stomach, that is called as acid pocket. But in this hernia kind of situation in reflux patients, this acid pocket makes more exposure of acid to the esophageal mucosa. So here comes the role of raft, which I think we are seeing many companies have come up with some alginate preparations with raft, which has a very good role in reflux diseases. So PPI are the cornerstone for even this group of patients, and they respond very well to PPIs. But as I said, sometimes diagnosis is made on the basis of symptoms. So the treatment also is very important to label them refractory GERD. Few of the patients don't respond to PPIs. They are classical heartburn. They use PPI but they don't respond to PPI. These are the patients in which we have to take twice daily PPI for at least 12 weeks to label them as if refractory GERD. And there is a big group of these patients, 30% of the patients they can have. Now causes, there are multiple causes. The most common cause is the poor compliance and poor adherence to the PPI. Now acid is not the only factor. Sometimes pepsin, bile and other secretions also increase this reflux. So we have to be very careful and we have to sometimes investigate them further. Now potassium competitive acid blockers drugs, these are newer drugs which are available now, vonoprazole, fexoprazole, which are very commonly used. They have definitely some advantage and very well FDA approved for reflux difficult cases. So they are rapid onset, not meal dependent. They are CYP2C19 minimal because we know that there are PPIs which are metabolized by, they are rapid metabolizers in which PPI don't work. So there you can use PPI which are called non-responders. PKFs are better drugs. Erosive GERD, definite indications. H. pylori is another indication in India where we can use PCABs along with nocturnal acid breakthrough. So GERD management is simple: lifestyle modification, acid pocket reflux management, acid suppression, and if not, then what? Then we have to embark onto the endotherapy as well as surgery. Now endoscopic therapies, there are evolving, now better available in few of the centers like Strata procedure and this GERD-X as well as ARMS, which is called. Now Strata is a system by which we put under vision we put the Strata catheter, which is a radio frequency ablation catheter, and at the tip of that G junction point we just burn out, in a latent terminology, we burn out the mucosa and that induces fibrosis which tightens the lower esophageal sphincter. So this is the Strata which has shown some good results. And then there is fundoplication, which is a very good surgical procedure which can be in these patients endoscopically. Now anti-reflux mucosectomy is a procedure in which around the basically G junction on gastric side we remove the mucosa and some mucosa is exposed for fibrosis. So that also tightens the basically lower esophageal sphincter and it has been found effective. If this doesn't work, then definitely we have to embark on the surgery. Now this is called fundoplication, which is a definite role in difficult cases with hiatus hernia and Hill's 3 and 4 patients, which is a classification of lower esophageal sphincter relaxation. So that's how we used to diagnose the GERD, we used to manage and the take home message for this talk would be that this is a clinical diagnosis which is very commonly seen, where is a very high prevalence because of our lifestyle, and these patients, if they should be investigated thoroughly if there are alarm symptoms, if there is atypical presentation, and drug of choice still is PPI along with now with newer PCABs. Endoscopic therapy is evolving, available, but the surgery is the last resort and still the gold standard in difficult cases. Thank you so much.
Thank you, Dr. Arvind. It's a very good topic, but because of the shortage.
How long PPI is safe? Secondly, can we combine PPI with newer drugs that PCABs? Is it better to take PPI twice or take PPI and take PCAB drug together?
So there is now plethora of data which has proved that PPIs are very safe. Although side effects of PPI has always been raised with, there are very good data because we are living in PPI era for last 3 decades and it has been found very safe in multiple meta-analysis. There has been no very significant side effects seen with PPI. So first question's answer is it can be given definitely for long time with very good safety profile. Number 2, combination not recommended as such. You have to diagnose what is the cause of reflux, as I have already enumerated with refractory PPI. So there we can definitely increase the dose or double the dose, which can help you out. With PCAB, there is no data for combination. It should always be given either PPI or PCAB. Rather, PCAB has been found better than PPI for erosive reflux diseases, and for recent data has shown that it has been good for even H. pylori therapy for India because dual therapy. And last question, I think.
Double dose of PPI.
Yes, it should be given. As I have written here in this slide, I think slides are not showing there. If there are persistence of symptoms because of say CYP2C19 metabolism, those are called as rapid metabolizers. So there is definite indication for double dose of PPI if they are not responding to single dose of PPI for say long duration for 12 weeks if compliance is good.
Lastly, the combination of PPI along with metoclopramide, levosulfide is safe with prokinetic. It is safe for a longer period or only using PPI?
Sir, actually in India, many of the combinations are available, but they are not FDA approved. It can be used because of dyspepsia, can be ulcer type or can be motility type. So if you find that if a patient is having dyspepsia with more of a burning symptoms, PPI alone is enough. But with burning symptom, if you find some bloating, some distension, post-meal heaviness, definitely you can add on with prokinetics.
Long-term safety of these.
Long-term safety, sir, it depends upon the drugs which you are using. Domperidone is safe. It is given in pediatric population. There are some side effects, but that can be very well clinically diagnosed. But other prokinetics like levosulfide is not safe. I don't use in my practice. Most of the time, yes, because it can have sometimes irreversible Parkinson syndrome. So for short-term duration, definitely safe. Long-term data is suggested this can have some life-threatening kind of conditions like Parkinson disease, which is irreversible. So if you say prokinetic is a group of drugs which can be having so many drugs. Metoclopramide is a long-term data. It is safe. Domperidone is safe, but levosulfide, nonsense.
Thank you. Thank you.
We have to take the questions later on because we are running short. Just one more question from sir, please.
No, just to tell that in a patient of the reflux disease, what is more important is you have to define the patient in a different category. What happened is the patient who can be very well managed nicely with the surgery, it is a duty of us to tell him that surgery is the best choice. The patient who has an intermittent reflux, you can give on-demand therapy. And patient who has a continuous GERD, in these patients you can minimize the doses because these drugs has to be taken for a very long time. So that needs to be discussed, which group of the patient you are giving a 20-year-old male come and who has a regular reflux symptoms. So it is important for us to guide when he is going to take for another 60 years. Number third, which is very important, we have to define, is it esophageal hypersensitivity, it is a functional heartburn, or it is a reflux disease. Just giving the PPI is not going to solve the problem. You do an esophageal manometry, do a 24-hour pH monitoring. That can very well differentiate, are you dealing with the motility disorder, functional heartburn, or esophageal hypersensitivity or reflux. We commonly see that is pH monitoring and the manometry is normal. You put the patient on the amitriptyline. These patients don't require PPI. So that characterization is very important. An on-demand patient says that I have a reflux once a week. You just tell him to take the antacids. That is more than sufficient when he's going for a party. Like tonight there's a dinner, if somebody has a reflux, he can chew the 2 tablets of the Diagene, that is sufficient. You don't require to keep on giving the medicine.
Thank you for your thoughtful remarks.
Thank you sir for sharing your knowledge.
कि मंजिल के आगे मंजिल तलाश कर वो मिल जाएगा दरिया तो समुद्र तलाश कर अब वो मॉडरेटर डॉक्टर आशीष शर्मा डॉक्टर मनीष मनोज मिश्रा सर डॉक्टर ज्योति गुप्ता डॉक्टर ज्योति गुप्ता सर give a big round of applause to our honorable chairperson Dr. Satish Agarwal sir.
Sir, group photo, sir, please.
Dr. Mayank Maheshwari and Dr. Satish Agarwal sir. I think
Sir, look at here.
Already done.
Sir, look at here.
he has been felicitated already, I think. He is one of our dignitaries for today's program. So the next topic will be